Today, I want to cover a really interesting topic that comes from a paper published out of Norway in the European Journal of Internal Medicine here, entitled De-Diagnosing: A Novel Framework for Making People Less Ill. And I think if it's interesting, that this is coming out of Norway when I wish it had come out of America. I wish someone in America had thought of it and published it, but it doesn't really matter as long as it goes widespread. But essentially, if you're part of the American healthcare model and you're older than 25, you've probably experienced this, whether you noticed it explicitly or not. And that is that conventional medicine in America, and I guess you could say probably Western healthcare overall, is very focused on the diagnosis. And the reason for that is that having a diagnosis is what triggers, that feeds the algorithm for what treatment that doctor is going to give you. It allows that doctor to be paid because insurance companies want to know what was the diagnosis they gave at that visit, which then, validates in the eyes of the insurance company the need for payment. And so, if you go into the conventional healthcare model, the focus is, well, let's label it, let's label it, let's label it. And we've been so, integrated into this model that we're used to it, and many patients, excuse me, especially patients dealing with chronic issues, will say things like, I just wish I knew what I had. I wish someone could tell me what it is. I wish someone, essentially, they're begging for a label or a diagnosis. And that can be okay if that leads to proper care. But as we'll see in this paper, the authors mention that oftentimes, at least in Western healthcare, the focus is more on the diagnosis than on the treatment. It's like the doctor did their job if they diagnosed you, not if they treated you well and made you better. And so these authors are talking about how overdiagnosis is common, and it leads to things like polypharmacy, which is you're taking too many medications. It leads to things like multimorbidity, which means you have multiple labels, which whether or not the labels are correct, it has a certain psychological impact on the patient and potentially stigmatizes the patient so that it has a social impact as well. So if we can be efficient in our diagnosis and efficient in our care, then we can make people less ill. It's a really cool concept, and it's pretty intuitive, but it's nice to see that it's backed up here with a paper and evidence. So let's just go through this here. The first thing they say right here is, today the International Classification of Disease, or the ICD-11 codes, consist of approximately 55,000 unique codes for diseases. So there's 55,000 different ways a patient could be labeled, or different things a patient could be labeled with, to the point where it's become that more behaviors, experiences, and social issues are given diagnoses than should be. So, for example, if your dog dies and you're depressed, that depression would actually be appropriate depression and natural depression. You lost a loved one. That's not something that needs to be diagnosed or medicated necessarily. It's, hey, your dog died. You need to process through that, and you get over it with time and whatever natural processing a person goes through. But if you go to a doctor after your dog dies and you're down because your dog died, in your record, they're going to likely put a diagnosis code for depression, and they may even recommend an antidepressant, which, my opinion, shouldn't be done. But then you end up on a medication for a life experience that's going to resolve itself. All these factors increase the number of people being diagnosed and drive, again, that multimorbidity and polypharmacy. So, walking into that doctor's office with no diagnosis, you leave with a depression diagnosis, Or if you had previous diagnoses of asthma, say, and now you walk in and you're depressed because your dog died and you leave with a depression diagnosis, now you have multi-morbidity or multiple labels, multiple disabling diseases, asthma and supposedly depression. And you may leave with polypharmacy because now you may have an asthma inhaler and Prozac. And so these things add up. And this raises the question of whether we've gone too far with diagnosing. So these authors say to promote health and destigmatize patients and give patients their psychological health back or contribute to better psychological health, we should be de-diagnosing patients. And basically what that is removing labels that aren't helpful to the patient. Okay. And at the same time, by removing those labels, we're removing medications that shouldn't be there as well. And that makes people less ill. And so up here, as you can see, diagnosis is a key part to healthcare. Like we said, it is the focus of modern medicine, and doctors, are even, the skill of a doctor is determined by their skill in diagnosis in conventional medicine. But again, if their skill is in diagnosing is good, but their treatment is poor, then what's the point? Okay. And then neither much time nor focus appears to be spent on reassessing and removing obsolete diagnoses. Diagnoses are found but rarely lost. Okay. So, for example, I go through people's medical records all the time before I first sit down with them because I'll consult with them for 15 minutes on the phone and before we determine if we're going to work together, and they'll give me a list of all the labels they've been given or diagnoses they've been given over their lifetime. And for some people, that's a very long list. You might have 5, 6, 7, 8 or more. And when you go through their medical records, you see the same thing. You see 5, 6, 7, 8, a list of that many different diagnoses because, again, they're given but rarely lost. And so a lot of times they have all the diagnoses listed and the date that they were given. And, if they're real, are they still manifesting in the patient currently with symptoms? That's one thing we want to figure out. But then also, at this list of diagnoses, is it supported in the medical record by labs or by scans or by physical exam findings to actually validate that diagnosis? That's another question we have to ask. Or did the doctor just hear a symptom, throw a diagnosis code on it so that they could be paid for that visit? The healthcare system persistently relies on formal diagnoses for healthcare attention, treatment, and economic reimbursement. Okay, we need to follow the money. And if a doctor's office is only reimbursed by giving a correct diagnosis, then being diagnosis driven is economically promoting, it's promoted by economics. So there's a kind of an economic conflict of interest there. We need to diagnose something, right? Each visit. So not good. What is a diagnosis? Diagnosis is defined by identifying a bodily or mental condition by symptoms, signs, markers, etc., which are considered to be of disadvantage or harm to a person's health. A diagnosis labels something abnormal that should be remedied. A disease or diagnosis refers to the physiologic dysfunction giving rise to illness. Moreover, diagnoses can result in stigmatization, discrimination, and psychological burden. Diagnoses influence people's identity and change the perception of a person for the person themselves, their caregivers, and society. Multimorbid patients, so patients with multiple diagnoses, report powerlessness, worthlessness, uncertainty, and anticipation. So again, doctors may not even realize they're having a psychological impact on a patient by giving a diagnosis or another diagnosis. But here is a list of things, the effects of a diagnosis. They trigger explanatory power. Okay, so that can be helpful, right? If a patient is saying, well, what do I have? Why am I suffering? If we've got the correct diagnosis, that helps us explain to the patient, well, here's what you have. And now that we know exactly what it is, here's why you're suffering, and here's how we can approach it and push back specifically. So that would be a useful example of the diagnosis, helping the patient actually become empowered and know what's going on with them, and then empowers the doctor and the patient and the doctor-patient relationship to take the right action to hopefully eliminate that diagnosis or optimize that patient's health, reduce their suffering. Diagnosis can provide attention, get the health professionals to realize, hey, this thing is real. Let's go after it. It guides action or treatment, like we said. It assigns social rights potentially, so allows access to care. It can personify or influence that patient's identity. That could go positively or negatively, right? If you tell someone they have cancer, that definitely changes their self-image in probably a negative way as opposed to a positive way. As opposed to other diagnoses that aren't necessarily as often terminal. Having the right diagnosis may help someone get workers' compensation and sick leave so that they can heal and get back to work faster. A diagnosis might cause anxiety, like the cancer example, or it might remove anxiety, like, hey, you don't have cancer, it's just it's just a enterovirus, it's just a gut infection, we can knock that out, no big deal. Oh, phew, I feel so much better now, right? So the diagnosis can imply status or prestige. Some people, identify too much with their diagnosis and brag about it. And then induce stigma and discrimination. A lot of times the mental health diagnoses may induce stigma and discrimination, like bipolar disorder or schizophrenia. Those things usually, at least more so in the past, when they were less well-known, less commonly diagnosed, there was more stigma and discrimination of them. So, and then lastly, the psychological and existential burden. So this is especially with terminal things. So, hey, you have stage 4 cancer, that definitely adds a psychological burden and maybe existential burden, like, oh man, I'm going to die, I have to get things in order. Have I lived my life right? All that stuff. So we shouldn't throw around diagnoses as if they're empty words, because they do impact a patient's psychology potentially. And through the field of psychoneuroimmunology, we know that your thoughts impact your immune system, your nervous system, your gut function, your overall health. So in summary, diagnosis can be polyvalent, meaning they can relieve or cause worries at the same time. They can result in cure or unnecessary treatment and harm. So we want to remove diagnoses that don't reduce a patient's suffering. And so the way that diagnosis has really helped diseases expand to that list of 55,000 different diagnoses is for two different reasons or two different drivers. One is medicalization. So basically, conventional medicine will take non-medical aspects of human life and make them a medical problem. For example, the dog dying and the normal depression associated with that afterward for a short time, or say a loved one, a grandparent dying, and we're depressed because we miss them shortly thereafter. That would be medicalization of a normal life experience, unnecessary to be diagnosed and medicated. And then overdiagnosis is the other driver. So diagnosing a condition that in the absence of testing would not cause symptoms, disease, or death in the person's lifetime. Okay, so this is labeling things that aren't even an issue. So maybe there's a blood test run and there's a finding that's high, but the patient has no symptoms, no history of it. And maybe the doctor, puts way too much focus on that and scares the person into treatment or into labeling themselves for no reason. That's a negative outcome. That's over diagnosing. So, despite the very best intentions, the way we organize the healthcare system fuels disease expansion and inflates the number of diagnoses. Healthcare systems should make leading to a healthcare system making people more ill. And that's not sustainable, as it will undermine trust and demand in the long run. So then people who have been overdiagnosed in the past for things that didn't matter, if they have a real diagnosis, they may be less likely to believe it and or take recommended action, and that really could end up hurting them and shortening their life. So that's one reason why we want to reduce the diagnosing. And box 2 shows consequences of too many diagnoses. Again, we've covered them some here, but unnecessary labels, unnecessary treatment, unnecessary concerns, increased demand on the healthcare system that is not necessary. So we don't want to overdo it. And so to show you an example here of what de-diagnosing looks like, they gave 3 cases here. Oop, where'd it go? Here we are. So we'll look at example 2. Here's an example of de-diagnosis. This is one that I've seen in my practice multiple times, and that's in this case a 56-year-old woman with type 2 diabetes diagnosis that she received 4 years ago comes into your office. And since she was diagnosed, she has started exercising, she's improved her diet, and she's lost weight. Okay. So now her hemoglobin A1C, which is your average blood sugar over the last 90 days, when it's greater than 6.5% or greater, they use that to diagnose type 2 diabetes. In the past, it was greater than that, but with her exercise, improved diet, and lost weight, it's now below 6.5. And she's not on, and she hasn't taken anti-diabetic drugs to get there. So basically, through lifestyle, she's reversed or eliminated her type 2 diabetes. So therefore, the type 2 diabetes diagnosis is not valid anymore. So the woman prefers not to have that diagnosis. She thinks it's stigmatizing. The diabetes diagnosis can trigger prescription of drugs, and the woman doesn't need the drugs. So that's another reason we don't need it. And the diabetes is considered to harm the patient due to stigmatization. So she can be de-diagnosed. The diagnosis isn't helping her. She doesn't need the drugs. She doesn't want to be labeled as it, and she's taken the action to eliminate the disease. So rather than allowing this diagnosis to follow her on her medical record for the rest of her life, it should be expunged. And there's examples here for a 20-year-old boy with a past ADHD diagnosis and a 94-year-old with osteoporosis as well. And so this is how it can look in real time. It helps the patient's psychology and self-image. It also makes sure they're not taking drugs they don't need to take. And it's kind of like a goal for the patient. If as the doctor you sit down and lay out goals, you say, hey, if this woman's Jane, if you start exercise, improve your diet, and lose weight, and that reduces your A1C, we can get rid of this diagnosis. That's a good clinical goal. Let's shoot for that. So de-diagnosis can be very powerful, and it's great that this is in the published literature, and I hope doctors and patients get a hold of this and set de-diagnosis as a goal, because again, the healthier we are, the less diagnoses we have. And, we all may be in a state in our lives at some point where we fit a diagnostic criteria, but it doesn't mean we have to fit that criteria forever. And we can change our state of health. And therefore, we should be able to change our diagnostic labels in our medical record.